My name's Chan Jeer. I'm an orthopaedic knee replacement surgeon and sports medicine surgeon here at One Hospital, Ashford. So I do a lot of knee surgery, particularly replacement surgery. Last year, about 400 replacements. I think the timing for knee replacement is really dependent on the individual. The benefits have to outweigh the risks. So in order to justify the significant risks of surgery, patients have to be in a significant amount of pain. And the main indicators that I look for are the severity of pain, the loss of function, and then we have to look at other factors, particularly age and looking at survivorship of the implant to balance survivorship of the implant with function. And therefore really patients have to be ideally old enough and in enough pain to warrant the risks. However, equally we are seeing a lot of younger patients with knee arthritis who warrant surgery. So it's the severity of pain and in particular loss of function such as sleep, walking distance, speed, ability to maintain independence. And I think once you've reached that level and you've exhausted all simple conservative measures, then that's the right time for a knee replacement. So we would always exhaust simple options, painkillers, injectables where they're available, physiotherapy, weight loss, optimizing medical conditions, and then once people have exhausted all of those and are struggling with function and independence, that's the right time for a knee replacement. I think the future of arthritis of the knee is very exciting. It's very easy to put in a chunk of metal and plastic. But ideally what these patients should try and do is preserve their natural knee for as long as possible. Nothing will feel as good or function as well as a natural knee. I think therefore a lot of what we do with knees in the future will be based on biologics, about preserving a knee, about looking at stem cells, about healing cartilage. However, there comes a point when those simple options simply can't work and then a knee replacement is inevitable. So the future of knee surgery, I think, in the younger patient with arthritis will concentrate on knee preservation strategies, the use of simple anti-inflammatories other than steroids, the use of stem cell therapies, the use of procedures to realign the knee so that mechanical pressures put through the knee are well aligned. And then the role of joint replacement to be as preserving of the knee as possible before eventually resorting to a conventional knee replacement. So in the treatment algorithm for arthritis of the knee, there are a number of conservative measures. The simplest thing you can do with an arthritic knee is lose some weight. And there's good evidence that if you optimize your body mass index and offload the knee, that pain will reduce. And then there are simple oral analgesics, anti-inflammatories if they can be tolerated. And then as surgeons, we can offer injections. One of the simplest things that you can be offered as an injectable is a steroid injection. It's good. The evidence would suggest that you might get 6 weeks of symptom relief with a steroid injection, but there are risks with any steroid put into the knee, particularly the risk of an infection at the time of introducing the steroid and in the future when you have a knee replacement. Anyone who's had any steroid put into their knee, whether it's 1, 2 or more injections, has a greater risk of infection when they have a future knee replacement. So to offset that risk, we have an injectable known as a viscose supplement. It's the closest man-made product that mimics normal joint fluid. It contains a substance called hyaluronic acid, and the substance I use is called Monovisc, and it's an anti-inflammatory, it's a cushioning agent, and combined with an aspiration of the knee, if there's a lot of fluid, it can provide very good symptom relief for many weeks and sometimes many months. And the ideal patient for that viscose supplement is someone with an arthritic knee who wants to avoid a replacement and wants to try a method of reducing pain and inflammation. There's a lot of mystery about what a knee replacement person can do with regards to sports and function. And as a simple bit of advice, what we normally say is you can go away, you can cycle, you can swim, but avoid anything more strenuous. And people get very upset about that, particularly young patients having knee replacement who want to be as close to their normal knee level of function as possible. So with regards to sports, it is risky performing contact sports. It is risky to run on a knee replacement. And ideally, I would say avoid contact pivoting sports. Having said that, it is possible to play doubles tennis, where you've got a partner who can do the running. It is possible to play golf. You have to learn how to modify your swing so you're not pivoting and twisting the knee so much. It's possible to ski, and I've got patients who ski very well. And it is possible to do some light exercise in the gym, but what you really want to do is avoid running where you're pounding and load bearing on one leg. In terms of kneeling, again, there's a lot of mystery about whether knees can actually kneel after a knee replacement, or indeed if they should. And one of the problems is the metal implant, and if you've got a kneecap, if you kneel and put the pressure through that kneecap, then it can induce a lot of anterior knee pain. However, 3 months post knee replacement, providing all's gone well and the scars mature and the kneecap's sitting in the right place, if you have a decent physio who can educate you about kneeling ability after a knee replacement, it is very possible. So one of the great problems with an upset knee is that you get pain, swelling, stiffness, and you lose function. And it causes great disability in people who limp and have pain, become very miserable after the onset of knee problems. One of the great issues at the moment is how do you get to see someone like me who's a knee specialist? And one of the ways we can help is give you the ideal assessment of your knee. We can investigate your knee with x-rays or MRI scan imaging. And the ability to see someone like me here at the One, it's very quick. You can self-refer, you can go through your GP. If you're insured, you have to go through your GP and use certain channels. But I think if you've got a bad knee and you're really struggling, the best thing to do is get it assessed. And that's what we're here for.